web seminars. Today we have a very important guest as the speaker, and he's the best in his field. So we have Dr. Dhananjay Lakkireddy with us. Thank you so much for joining us early morning from US, and Dr. Haigreve Rao. Both of them will take over as the moderators, and we'll start the session. Excuse me, Dheeraj, can you please put everybody on the mute? Yeah, both the moderators kindly unmute yourself, and the speaker please unmute yourself, and over to you both, Dr. DJ and Dr. Haigreve. You have to unmute yourself, DJ, please.
Yeah. Thank you, Manita. Thank you for the opportunity. I think this is a terrific topic. So looking forward to Dr. Ajit Kumar's presentation.
Without diabetes, but in my personal opinion, it's going to be for.
Hi, everybody.
Nice topic.
Hang on for a minute. Let me just get this. Yeah, is that visible there?
Yes.
Yeah. Good evening, everybody. I think I should first thank the IHRS team, especially Dr. Saksen and Dr. Vanitha, for having given me an opportunity to come and speak to you on this particular topic. And Dr. Reddy for having joined from US all the way, and Haigreve for co-chairing. So the topic is MRI imaging in cardiac arrhythmias. It is a pretty vast topic, so I need to sort of reduce it such that it can be clearly understandable. We have been interested in MRI imaging in cardiac arrhythmias for quite some time. Our team has an additional radiology group, which basically has a DM in cardiac imaging sciences. So we have a sort of combined discussions and planning of most of these MRI imaging with them. And probably that sort of helps us. And that's what probably I think everybody should be doing. You should have, in combination with the radiology group, you need to develop this aspect. So what are we going to discuss today? So we are going to, the scope of my talk is on what is MRI scar imaging, MRI imaging in cardiomyopathy, the scar characteristics, signal intensity, heterogeneity, and T1 mapping, MRI in AF, hypertrophic cardiomyopathy and non-ischemic cardiomyopathy, and finally coming to imaging and 3D mapping for VT ablation. Let me just check my screen. Yes, okay. Is my screen visible? Is my screen clearly visible there?
Yes, sir. Beautiful.
Yeah, yes, sir.
Yes, yeah, fine.
Clear, sir. Clear.
So what is MRI scar imaging? Now, if you look at the physiological basis of scar imaging, it is based on the tissue persistence of the contrast agent gadolinium. Gadolinium essentially shortens T1 and increases the signal intensity with consequent hyper-enhancement. The difference of longitudinal recovery times is compared to the normal myocardium. So the gadolinium diffuses from the vascular to the interstitial space, but it is excluded from the myocyte intracellular space. Essentially, the gadolinium that comes and stays in the interstitium is the basis of the physiological basis of this delayed enhancement. In the chronic scarred phase, the myocardial scar is characterized by increased collagen content and increased interstitial space, and that is where the gadolinium accumulates with the delayed enhancement. So to put it and to demonstrate it, you see in this normal myocardium, you can see the gadolinium does not involve much of space. While when you have acute MI, you can see that when the cell membranes is disrupted in acute MI, the gadolinium sort of comes and involves the intracellular space as well, and there is early enhancement. And when there is scar and when there is increased interstitium and fibrosis, you find that the gadolinium comes into the interstitial space and has not only the gadolinium comes and stays in for a longer time, but the enhancement is also more. So this is the essential of the delayed enhancement. And as you can see,
which actually correlate the class 3 symptoms.
As you can see, when in the blood pool, when you inject the contrast, in the normal phase, you'll find there is an enhancement into the interstitium, but then it sort of dwindles with time. While when you, in patients who have fibrosis, you can find that the gadolinium comes into the interstitial space and remains for a longer time because of delayed clearance. This delayed clearance of contrast in the interstitium is the cause of delayed enhancement, which basically images the scar. So let us look at the scar assessment. Now, LG is a preferred technique, and it is based on signal intensity of the affected region as compared to the healthy myocardium. So one should understand this signal intensity that is seen is always in comparison with the healthy myocardium. If you have the entire myocardium which has a high intensity, then you cannot see the difference. So in a binary approach, it characterizes the myocardium as normal versus the scar. While in a ternary method, it uses three categories. You have a dense fibrosis or a scar core. You have a moderate fibrosis or a scar border zone, and then the normal myocardium. So you can essentially have two approaches. One is a normal and a scar, and the ternary methods, you can sort of have dense, moderate fibrosis assessment as well as the normal myocardium approaches. Now, how is fibrosis that relates to arrhythmia? Now, if you look at the pathophysiology of myocardial fibrosis, you can see we used to assume that the cardiac fibroblast is essential and inert cell, which is not. It represents a cell type which comprises of about 20% of all the cardiac cells. And these cardiac fibroblasts initiate signals and affect production of different microRNAs, which has an effect in atrial and ventricular arrhythmias, hereditary cardiomyopathies, heart failure, DCM, and hypertrophic cardiomyopathies. And as you can see, when there is anisotropic conduction, you find that the conduction velocity is certainly reduced, and which is also true in fibrosis. When you find there is when you find there's a normal potential, there is homogeneous conduction. But whenever there is functional isotropy or when there are pathological barriers due to fibrosis, you can find that there are fractionated potentials leading to reduced conduction velocity. Now, coming to specific aspects, let us look at the MRI in cardiomyopathies, especially with the aspect of risk assessment. So why do we need to do an MRI in cardiomyopathy? For diagnostic reasons, for LV function assessment, to quantify regurgitation, for scar mapping and quantification using LG, then anatomical integration with 3D mapping, and of course, if it is feasible and possible, into VT ablation. So let us look at some of the LG patterns in MRI assessment of cardiomyopathies. Now, the typical cardiomyopathy which is seen is the ischemic cardiomyopathy, where you find subendocardial LG enhancement. And this can be transmural when the entire wall is enhanced. In non-ischemic cardiomyopathy, where the MRI is very useful to give us a diagnostic information, you find the mid-wall hyperenhancement is typically seen in non-ischemic idiopathic dilated cardiomyopathy. A hypertrophic cardiomyopathy also you can see a mid-wall enhancement. And when there is sub-epicardial enhancement is seen in sarcoid, and a concentric subendocardial enhancement is typically seen in amyloid. Now, this is all important for us to diagnose the varying etiological aspects of non-ischemic cardiomyopathy. So when we looked at our data of non-ischemic cardiomyopathy, we could find that etiologically, idiopathic dilated cardiomyopathy formed about 74%, sarcoid formed about 2%, and myocarditis formed about 5%. Now, looking at the specific scar patterns, we will discuss of the other disease in detail. But if you look at the scar pattern in ischemic heart disease, which is basically a very common problem, you find that the subendocardial enhancement conforms to the coronary territory. And now here it is less than 50%. And when you have more than 50%, you would call this as transmural involvement. And when it reaches 75% of transmurality is involved, then you tend to get ventricular arrhythmias. Now, coming to some very specific aspects before we go into the specific problems in cardiomyopathies. Now, what is scar heterogeneity? Now, LG represents scar as we have understood. It basically indicates hyper-enhanced pixels. The scar is defined as more than 2 standard deviation of mean signal intensity as compared to remote myocardium. In other words, a scar means increased enhanced signals, but then that is as compared to the remote myocardium. The scar heterogeneity represents varying pixel density of these scar, which can have which can have a standard deviation anywhere from 2 to 6 standard deviations, and these are color coded. The scar heterogeneity actually correlates with the border zone scars. So how to identify the heterogeneous scars with two? So the heterogeneous scar will have irregular border, can be seen in islets, can be a variable signal density, and is generally non-transmural. So if you see this picture, you can see this is a scar with significant increased intensity of the pixel. And at the border zones, you find the signal density is less. So basically, now these are scars with containing both intensely enhanced density as well as with reduced density, indicating that these are heterogeneous scars. And the heterogeneous scars can be color coded. So what is the significance of this so-called scar heterogeneity? The scar heterogeneity correlates with ventricular arrhythmias, and it correlates with VT inducibility with appropriate ICD therapy and sudden cardiac death. And heterogeneous scar is more likely to produce VT in ischemic cardiomyopathy. And what do they in general represent? They represent border zones and scars. And they are important in VT mapping and for isthmus evaluation while doing VT mapping, especially along with MRI. So the next aspect which needs to be understood is what is T1 mapping. Now, LG is not useful in diffuse disease or fibrosis as there is no zone to compare the signal density, which basically means if you have a diffuse disease, the entire LG will be the same in the entire myocardium. So you can't compare it. So you need some other factor to see what is the absolute value of these areas which have diffusely diseased. So T1 measures the longitudinal relaxation times in times or milliseconds, which are determined by their spins after being excited by an RF pulse. So T1 mapping refers to a pixel-wise evaluation of the absolute relaxation times on a map, which can be color coded. The normal T1 relaxation time is 950 milliseconds. And T1 high values are seen in fibrosis edema, and T1 low values are seen in lipid and ion overload. To clarify it further, now you can see when a T1 map is done. Now this is mapped against the extracellular volume fraction, to which we will not discuss. But basically, if you have a T1 value of normal, which is around 950 milliseconds, any increased T1 values in those areas are seen in hypertrophic cardiomyopathy, idiopathic dilated cardiomyopathy, myocarditis, amyloid. And T1 values are reduced in conditions with hemocentrosis or when there is lipomatous metaplasia. So if you put your T1 value to a specific segment of the ventricle, and if you find that the T1 values are high, it basically indicates increased amount of fibrosis. So let us look at this particular cartoon. Now you can see the LGE in the middle segment in hypertrophic cardiomyopathy patient. Now there is in the anterior segment, you can see some amount of patchy LGE. But in the other portions of the interventricular septum, it is not evident. While when you do a T1 map, you can see it is reddish in color, which basically indicates that the T1 values are high and there is evidence of fibrosis in the entire interventricular septum. If you look at this dilated cardiomyopathy, and if you look at this LGE, there is no evidence of late gadolinium enhancement on the interventricular septum. While when you do a T1 map, you can find that there is a greenish yellow, which basically indicates that there is a tendency for the T1 values to be high and evidence of early fibrosis is evident. And in a patient who has heart failure with preserved ejection fraction, again, when you do a LGE assessment, you find that there is no evidence of LG enhancement, but which is not again true when you do a T1 map. You can find that there is some amount of increased fibrosis as seen by this yellowish reddish appearance. And as you can see, the greenish segment is normal. The bluish segment is around 200 milliseconds, which is below normal, and towards red, which is about 1600 milliseconds, is increased. So T1 mapping gives you an idea of the fibrosis, irrespective of the late gadolinium enhancement. So coming to some specific aspects of cardiomyopathies, let us look at the MRI in non-ischemic cardiomyopathy. The prevalence of LG scar in non-ischemic cardiomyopathy is seen in about 41% of cases. The remodeling process in DCM is characterized by changes in extracellular matrix and fibrosis. And the fibrosis that is detected by the LG in NICM is a marker of arrhythmias and sudden cardiac death. Now, the LG scar that is seen in NICM is associated with a 2.5-fold increase in mortality and about a 5-fold increase in arrhythmic events. And the typical scar pattern, when you send a patient with idiopathic dilated cardiomyopathy and when you ask for the MRI, what you are likely to see is a mid-myocardial enhancement, as you can see here. This is from one of our patients. So this is a typical mid-myocardial enhancement. And when we look at our data, we could see that the LG pattern in our patients had a mid-myocardial, right? About 75% of patients had a mid-myocardial enhancement. There was patchy enhancement in 75%, and the ventricular septum was predominantly involved in about 92% of the patients. And when you look at the scar size and the arrhythmic load, you can note that once it reaches above 5% to 10%, then the arrhythmic load is certainly increased, which is not true about patients with mild LG enhancement. We looked at our data and we could see in non-ischemic cardiomyopathy, which we recently published. Now, the MACE, the cardiac death, heart failure hospitalization, sudden cardiac death, and VT were all increased in LG positive patients in non-ischemic cardiomyopathy. And when we try to correlate what is this amount of LG that is critical to make a decision of need for an ICD or increased evidence of arrhythmias, we could find that the values were about 14%. So anything more than 14% LG enhancement carries an increased risk for cardiac MACE. So we will call this as a rule of 15%. Now, the HRS 2017 guidelines said that the indication for doing a cardiac MRI with late gadolinium enhancement is class 1 for diagnostic purposes. And it gave a class 2 indication for assessing the risk of sudden cardiac death. I think that probably needs to be elevated to class 1 maybe with some more data to come. So what did we learn? So we learned in non-ischemic cardiomyopathy that the prevalence of LG scar is about 40%. There is a mid-myocardial localization, that the LG presence is prognostic of MACE, ventricular arrhythmias, and heart failure. And the quantum of LG of 15% carries significant arrhythmic risk and should be weighed during evaluation for primary ICD prophylaxis. So let us now look at the next aspect, that is of MRI in hypertrophic cardiomyopathy. Most people ask this question that do we need to do an MRI in all patients with hypertrophic cardiomyopathy, especially the electrophysiology group. So why should you need MRI in hypertrophic cardiomyopathy? To assess the ventricular function, the hypertrophy patterns, to assess the asymmetric septal hypertrophy, assess the SAM, mitral valve abnormalities such as a lengthened anterior mitral leaflet, papillary muscle abnormality, and perhaps the most important for arrhythmic risk assessment with LGE. Now, the sudden cardiac risk assessment in hypertrophic cardiomyopathy is based on the conventional factors such as unexplained syncope, the NSVT, family history of sudden cardiac death, severe left ventricular hypertrophy of more than 30 millimeters wall thickness, abnormal BP response and exercise. And with this, we need to add LGE. Now, the presence of more than one of these risk factors will need an ICD for or as a primary prophylaxis for hypertrophic cardiomyopathy. So let us look at the LG in hypertrophic cardiomyopathy as such. It reflects myocardial scarring, reflects load conduction with consequent EP effects of myocardial disarray, and hypertrophic cardiomyopathy with high risk of sudden cardiac death shows a higher prevalence and a larger extent of LGE. And this, of course, as we said earlier, is patchy and mid myocardial. And a meta-analysis of this LGE in hypertrophic cardiomyopathy has now concluded that LGE on MRI is significantly associated with cardiac death, heart failure death, and all-cause mortality. Now, earlier meta-analysis showed that the reduction of sudden cardiac death was not significant, though there was a trend. But recent meta-analysis by Wang et al. Had shown that the extent or the quantum of 15% of LGE or more than 15% of LGE was predictive of increased sudden cardiac death and risk. And it is not the binary variable of the presence or not. So basically saying that 15% of LGE was predictive of arrhythmic risk. And as you can see, the all-cause mortality, cardiac death, and sudden cardiac death were all increased in this meta-analysis. So coming to the risk assessment, as you can see, now in the prevention risk stratification model, the conventional risk factors of family history of sudden cardiac death, unexplained syncope, NSVT, abnormal BP response, and massive LVs that we discussed earlier. In addition to that, you need to add this LG of more than 15%. Now, other factors that could add will include end-stage phase of the disease, LV apical aneurysms, marked LV outflow obstruction, and CAD, and maybe even alcohol subtle ablation. Now, when we look at our data, so we ask a critical question: can LG predict ventricular arrhythmias in our group? So we had seen that 56% did not have any LG in our patients, and 33% had a mid-myocardial gadolinium enhancement. And this was the pictures that we was having, a mid-myocardial enhancement, as you can see. This is a subendocardial pattern of in HCM. And when we specifically look at the correlation between LG and ventricular arrhythmias, what we saw was that in patients who did not have LG, ventricular arrhythmias was absent in 87%, while arrhythmias was present only in 12%. While in patients who had LG, 56% had ventricular, did not have ventricular arrhythmias, and an equal number had ventricular arrhythmias. So the presence of LG was not clearly correlative of arrhythmias. It showed an equal presence and absence of ventricular arrhythmias, while the absence of LG showed that there was no ventricular arrhythmias. So what did it basically mean? It basically meant that if you have LGE, it is likely that the patient may have arrhythmias, but the absence of LGE means that this patient is not likely to be a candidate who will have ventricular arrhythmic load. Now, coming to T1 mapping in hypertrophic cardiomyopathy, this is also a part of the study that we did. We did a T1 mapping using a SMART1 protocol. T1 mapping of hypertrophic cardiomyopathy patients were done and compared with LG to evaluate diffuse fibrosis that I discussed earlier. And what we saw was that the native T1 values were higher in patients with LGE and without LGE, indicating diffuse early fibrosis is common in hypertrophic cardiomyopathy. So in fact, in people who had LG present and who were absent, both of them had a high T1 value, indicating the presence of early fibrosis. So this is a typical picture that we had. He did not have, if you look at the polar map alone, if you look at, there was no evidence of LGE, but there was increased T1 value. And in patients who had, in this polar map, who had LGE, even they also had high T1 values. So irrespective of LGE, the T1 mapping values showed a higher values in indicating thereby there was probably evidence of diffuse fibrosis, even in patients who did not have LG positive. So what did we learn? So we learned that in patients with hypertrophic cardiomyopathy, ventricular arrhythmias correlates with LG on MRI1. The absence of late gadolinium enhancement on MRI carries a high negative predictive value and a low risk for ventricular arrhythmias, while the presence of LGE, the mere presence was equally seen with and without ventricular arrhythmias, And the mere presence cannot be a recommendation for ICD prophylaxis. But however, the LG of more than 15%, in addition to one conventional risk factor, is an indication for ICD prophylaxis. So I will repeat that. It is not the mere presence of LG that is important, but it is the quantum of LG that is important. And the presence of more than 15% is again an indication, especially when added to one conventional factor, an indication for ICD primary prophylaxis. T1 mapping in hypertrophic cardiomyopathy, as we discussed, was suggestive of a high prevalence of diffuse fibrosis irrespective of LGE. Now let us come to this very important aspect of our discussion, that is MRI-assisted VT ablation. Now, MRI-assisted VT ablation has the following aspects. We need a functional assessment of the ventricular function. We need image integration. We need scar quantification and characterization. And in that scar characterization, we need border zone assessment, and we need conducting channel identification for VT isthmus localization, something which we will clarify. So how do you find out the VT substrate? And what are those issues that are related to VT substrate evaluation when you get an MRI scar? So one, it helps in the localization. So you can specify whether the scar is endocardial, intramural, or epicardial. And if you have an epicardial scar, you need to get an epicardial axis. We need to look at the pixel signal density for border zones. We need to look at the transmurality. That means how much myocardium is involved. The sites for VT maintenance is generally confined to more than 75% of the transmural scar. And they are generally have core as well as border zone sites. And slow conduction are also seen in these transmural scars with an SQRS interval of more than 40 milliseconds. It also gives an idea of the size, shape, and complexity when you start doing an electroanatomical map. So now what is the signal intensity that is so critical in this MRI characterization of the scar? The signal intensity, or the SI of the scar, essentially helps to differentiate between core areas and border zones. Now the pixel SI thresholds of 60% and 40% of this maximum SI, or the pixel density, is characteristic of border zone and scar core regions. And this PSI map is color coded, which is the equivalent of voltage electroanatomic mapping. So let me just clarify that. So as you can see here, now this purple is normal myocardium, and this pixel density, which is high, that is of scar. And this border zone is the zone between this red and purple, yellowish green, which is the border zone. So in short, characterization of this pixel density between 60% and 40% of the maximum SI gives you an idea of the scar, the normal myocardium, and the border zones without an electroanatomic mapping. So how do you characterize, now having realized where the scar is and having realized where the probable border zone is, how do you exactly characterize the isthmus using MRI? So we said that the myocardial scar contains a VT circuit, and the scar contains the conducting channels and the probable VT isthmus. And we also know that the substrate ablation techniques considers the conducting channel elimination as critical to VT ablation. So how do we really find out where the isthmus is? So the conducting channels is identified by the MRI reconstruction, as we saw, and the scar core is the dense hyper-enhanced red areas. The purple zone is a normal myocardium, and the border zone is the reflecting areas of heterogeneous non-dense hyperenhancement that we saw, which carries a slow impulse conduction. And this contains the VT isthmus and is evident in a color-coded PSI map, as we saw earlier. And the border zones correlates with VT isthmus on electroanatomic mapping. As you can see, this is a typical electroanatomical mapping of a VT circuit. You have the voltage map shows this normal myocardium. You have the scar, and you have a border zone here. Now, this is an MRI scar map. shows normal myocardium, a hyper-enhanced scar, and you have what is shown as a border zone, which is likely to contain your VT isthmus. And this is an integration of these both into the electroanatomic mapping. And as you can see in the electroanatomic mapping, if you modify your cutoff values of 0.5 and 1.5, you can see the channels will change. And in a similar manner, when this is the scar and this is the normal myocardium, and we change the values of 40% and 60%, you can modify the channels to see how big these channels are and where you need to ablate. So the typical electroanatomic map of a VT, and this is the MRI-based, scar-based map, which shows that the border zone matches almost excellently with the electroanatomic mapping. Now, those of you who think that electroanatomic mapping is the ultimate in voltage mapping, you can see that when you have three wavefronts created by RV pacing, LV pacing, and BIV pacing, which are different, then the scar maps also change. So there is a bit of change in everything. So the specificity of the map needs a combined integration. So when we compare with the MRI-based ablation or MRI-aided electroanatomical mapping-based ablation, and that with the pure electroanatomic mapping-based ablation. So we have 159 patients in a study with VT and SCAR. 54 patients underwent PSI-based MRI-guided electroanatomic mapping combined ablation versus the standard electronic mapping-based ablation, and followed up for 20 plus minus 19 months. And CMR-guided ablation had a lower recurrence rate and an event-free survival. As you can see here, the CMR plus electroanatomic mapping-based ablation had a better response than a long-term recurrence as compared to electroanatomic mapping. Now, as a last point, I would like to say this, this evaluation based on MRI generally tends to correlate with the thinning as seen in CT. So people tend to now start integrating CT also along with this MRI and electroanatomic mapping. So how do we do it ultimately? The actual question is, how do we do it? What is the workflow? So you have an anatomical delineation of the MRI scar, which is not difficult. You need to have an MRI scar characterization into a scar core and border zone, which is not difficult, but you need to have the software. The segmentation of the image is done for export as 3D meshes. You need color coding of SI maps of all these voxels, which are not difficult, but you still need the software for that. You subsequently, you take that to the lab, like as much as you do in atrial AF ablation. You need registration in the cath lab, and with this done with the help of coronaries, and then you do an electroanatomical mapping. Well, this is an interventional suit, and I understand this in Sunnybrook. Dr. Reddy should clarify that. So if you have time, I could just go on to MRI in AF for another 2 minutes. Why do we need to do MRI in atrial fibrillation? You need MRI in atrial fibrillation to find out the atrial pulmonary vein anatomy, the anatomy for registration and image integration if it is possible with MRI, diagnostic for the reasons of heart failure, scar assessment and quantification for AF ablation. So this is atrial enhancement. As you can see, there is significant atrial enhancement. Now, this can be color coded. The healthy myocardium is blue and the green is scar. The DCAF study, which was a study on atrial fibrosis and AF ablation, was a multicentric prospective study in paroxysmal and persistent AF to see the outcome of atrial fibrosis. The aim was to see the feasibility of atrial fibrosis quantification with LG and its relation to AF ablation outcome. And the recurrence was noted at 325 and 475 days. And this is an interesting characterization of the atrial LG. When you have less than 10%, it was stage 1. Stage 2 of the scars was 10 to 20% of the LA. Stage 3 was 20 to 30%, and stage 4 was more than 30%. So it was seen that the AF recurrence was significantly high in stage 4 when the quantum of LG was more than 30% and was least with stage 1. So what does that all boil to? So in a patient who has significant atrial fibrosis, which you suspect, and if you have done an MRI, if you have atrial fibrosis of more than 30%, there is probably no point in doing an AF ablation. If it is less than 10%, you could go by the standard PVI with or without homogenization. But anywhere between 10 to 30%, you need not only pulmonary vein isolation, you will need further, which would include a scar homogenization. We did an evaluation of atrial fibrosis and rheumatic heart disease assessment, and it was interesting. The late gadolinium enhancement of LA was seen in all 100% of patients with atrial fibrillation related to rheumatic heart disease. Diffuse biatrial LG correlated with the severity of the valvular lesion, valvular enhancement, and LA size. And biatrial LG was seen more often in AF than in sinus rhythm. And this was not seen as a consequence of LV dysfunction. So you can find that in 58% of the time, there was biatrial plus pulmonary vein enhancement in rheumatic AF. Now, you could see that there is atrial enhancement in the atrial septum on the LA free wall, and this image is not very clear, but it's also seen in the pulmonary veins. So the take-home message of LG in AF is that LG in AF indicates atrial fibrosis. Significant atrial fibrosis is indicative of AF recurrence following AF ablation. Rheumatic heart disease has significant LG and atrial fibrosis prominent in mitral valve disease and AF. And we propose that atrial cardiomyopathy is common in rheumatic heart disease and is invariably present in rheumatic heart disease with atrial fibrillation. Conceptually new and a provoking statement, it should be interesting that the fact that there is atrial cardiomyopathy in patients with AF based on the LGE pattern. And obviously no role for RFA in rheumatic heart disease related AF. So for a long talk, I would conclude by saying this, that the LGE or late gadolinium enhancement in cardiomyopathy characterizes and quantifies the scar. The pattern is diagnostic of the nature of cardiomyopathy. The ejection fraction and gadolinium enhancement are the best predictors of ventricular arrhythmias and the need for ICD. The scar quantum of the rule of 15 dichotomizes this high risk. Atrial LGE fibrosis suggestive of atrial cardiomyopathy and has a high AF recurrence following AF ablation. MRI imaging is useful for integrated 3D mapping, for border zone evaluation, substrate evaluation, in scar-related VT and substrate-based VT ablation certainly will improve with MRI-based integration into standard EAM mapping. Thank you. This is our team. I think there are two more people. One, Dr. Abhilash is there, and Dr. Sridhar, our fellow, is there, and Dr. Mugund is also there. Thank you. Thank you, everybody.
Dr. Ajit, it's a great talk. Some curiosity, investigational curiosity, which was there in 2008 and 10, probably it has become a situation where you just can't go without a cardiac MRI in evaluation of heart failure and arrhythmias in many centers now. We do have share your data on cardiomyopathies, but before I want Anita to put up the slide. We too had the only difference that why I put up this slide was to differ. We used a scar cutoff of 5% or 6%, sorry, and then we looked at 133 patients, and with a follow-up of about 2 years. And you can see that NICM and ICM are approximately equally represented. And we looked at patients less than 30% and more than 30%. The cutoff for the inclusion were 40%. So the patients above 30% were 30 to 40%. So what I wanted to show was when we took a 6% LG percent, and all these were gadolinium enhanced scars, those patients in ICM, they predominantly had a larger amount of LG positive. You can see that 24 out of 27 patients had this. And these were the patients who conventionally receive ICD. But then we looked not only arrhythmias, but all the cardiovascular events, heart failure as well as arrhythmias. And we found that the majority of the patients who had cardiovascular events were LG positive in EF 30%. And also in the EF more than 30%, which you are emphasizing, all those patients who had events were with LG positive. Now, the value we found more in NICM, as you also found out, because of the controversy of the ICDs in less than 30%. But even here too, it was LG positive with patients with NICM and less than 30% who had events. So by and large, we had an extremely important, valuable information from cardiac MRI, but we have not used this criteria to use ICDs as on yet. But I think I agree with your data that we look forward to a lot of incorporation of MRI in this. And having said this comment, one question I want to ask you is, how easy did you find doing MRI with patients who already had ICDs and VT storms or recurrent VT? How much difficulty in terms of artifacts and things your people found?
I find that what we have done in some patients, but it's actually quite difficult, not because of the ICD presence that can be taken care of, but basically because it caused a lot of artifacts. Even wideband imaging that we have done, still it results in significant amount of artifacts. So that's a problem area. I would say it's difficult.
Dr. Ajit, that was a fantastic talk. This was probably the most useful talk in cardiac imaging I've heard in a long time. So thanks for simplifying the concepts really well and kind of driving home some of the important points and the caveats that we face in utilizing cardiac MRI. So we have a bunch of questions from the audience. So I thought it would be nice to kind of go. So is it okay if I read those questions to you? They're actually in the chat section. So we have a first comment and a question from Jaikirti Rao. In the non-ischemic cardiomyopathy patients, what does elevated ECV indicate? And considering your slide showing T1 mapping, LGE and ECV, is it of the same relevance as LGE? And if LGE is not raised, can the ECV be elevated?
See, the LGE, the presence of LGB has only been assessed in terms of the arrhythmic risk assessment. And it is not merely the presence of LG, but the quantum of LG that becomes significant as far as the studies have shown. So more than 15% involvement of LG is certainly an indicator for increased arrhythmic risk. And thereby you can take other factors into control and then do a primary prophylaxis. That's one. Now, the presence of T1 map indicating extensive fibrosis is not proven to be an indicator for a risk assessment in terms of arrhythmia, not for an ICD implantation. So the answer is no. T1 mapping by itself is an indicator of what is going to happen, but it is not proven as yet. And we'll have to look at this data.
So, and then as an add-on to that question from Ashish, do you report regional distribution of T1 values? And if so, does T1 mapping allow you to be used in renal dysfunction without with patients who have significant renal dysfunction?
We do T1 mapping, but then we don't really integrate that into the clinical practice because basically it only gives you a clue, but basically we rely only on LGE. But renal failure, yes.
There's a question from Deepak Padmanabhan. who was asking about what was the time gap between the MRI no LG group and onset of ventricular arrhythmias. Was there a linear correlation or a time plot to how the scar characteristics evolve, and how is that correlated to ventricular arrhythmias?
In which group of patients? In the hypertrophic cardiomyopathy? Now we no, I cannot exactly say the time frame, but the patients that whom we assessed in terms of hypertrophic cardiomyopathy, there were patients, a significant amount of patients did have an ICD in, and whose patients who had LG done or MRI done earlier. Now, in patients who had, so which was correlated with time. Now, in terms of cardiomyopathy patients of non-ischemic variety, the time frame is not really clear, but as I can remember from my memory, is around 2 to 3 years. The increased as the events start increasing.
There was a question about how does the PVCs impact the MR quality, and how do you really use the LGE in hypertrophic cardiomyopathy for ventricular arrhythmias? Is that the presence or absence of PVCs or non-sustained VT, or do you typically look for more sustained forms of arrhythmia before you embark on a MR imaging in these people?
We do MR imaging as for all patients with hypertrophic cardiomyopathy. PVC is a problem, but we try to give drugs and sort of control it. It has never really been a problem such that it might get postponed. So we take care of that. Now, I would like to address the question of PVCs also in MRI. In patients with RV outflow PVCs, we were actually initially doing MRI to assess is there any pathology involved. What we found was the so-called idiopathic group did not have any significant LGE. However, we could actually pick up a few patients with ARVC and all, but by itself, the PVCs of the so-called idiopathic variety did not have any evidence of structural heart disease as revealed by LGE. NSVT and all, of course, certainly they would not be as a problem because they are not going to be taken into for evaluation hypertrophic cardiomyopathies for MRI at the same point in time. If that answers my question.
So there was a question and comment from Yash Lokhandwala. He was commenting about the individual differences in the scar pattern in the atrium, whether mitral stenosis is present or not. Can you elaborate more on the impact of a predominantly MR lesion or a predominantly stenosis lesion? Did you find any individual differences, or was it, I mean, mostly if you have rheumatic heart disease, you're bound to have extensive amounts of scar tissue irrespective of the type of valvular lesion that you deal with?
See, that was an interesting concept. I was actually initially sort of intrigued by this presence of LG that we used to see in a lot of patients with rheumatic heart disease when we do. Initially, my evaluation was on what is the cause of LV dysfunction in rheumatic heart disease, LV dysfunction. So we tried to find out the LV component, and we didn't see much of LG in patients with rheumatic heart disease with LV dysfunction, thereby indicating that fibrosis is not a component in the ventricular function. But at the same time, I started noticing that you find a lot of patients having atrial enhancement, which led us to this, looking at the atrial enhancement, lateral LGE in patients with rheumatic heart disease. Now, to answer that question specifically, be it mitral regurgitation or mitral valve disease, stenosis or regurgitation, that does not affect. The LG is the same in both these groups. In fact, even patients who had isolated aortic regurgitation also tended to show atrial enhancement. So much so that it sort of gave us an idea. We were wondering whether it is all false pickups. But looking through it seriously still, we think it is basically the values are correct, the enhancement is proper, and it all reflects that the atrium is significantly and more involved in rheumatic heart disease process.
So there's a question from Dr. R.D. Yadav. Understanding the obvious lack of extensive data on the predictive power of T1 imaging, in your experience, have you seen increased T1 presence in the myocardium in those patients who have interstitial fibrosis Or do you think T1 mapping actually has the potential to predict or detect myocardial disarray in some of the hypertrophic cardiomyopathy patients?
Yes, this was a study which has been done and probably will soon get published, be it done in hypertrophic cardiomyopathies, T1 mapping. And to our surprise, the T1 mapping seems to be increased in all patients with hypertrophic cardiomyopathy, so that we are now really looking at methodological issues. Is it that we were fundamentally wrong? Because both the ones with LG and without LG showed significant T1. But I actually think that is basically an evidence of fibrosis.
And then there was a question from Anup Gupta about workflow in patients who have existing NICDs or cardiac devices. How do you accomplish a good quality MRI that could be potentially be useful both in understanding the scar patterns and also incorporating the data into your workflow for ablations?
See, as I said earlier, it is difficult because of artifacts. And the artifacts are now being taken care of by using wideband imaging. But I still find that you're not really sure about even LG presence. So you will still have a lot of difficulty in actually getting a proper scar map, pixel density evaluation. So I think the answer is probably not, if you're talking about real scar imaging. For diagnostic purposes, if you want to include everything into it, that means you see the morphology, then of course, yes.
So with that, I actually have a comment that aligns with some of the comments that I saw on the question. So, I mean, we do a lot of MRI for PVC evaluations and non-sustained VT evaluations. These are the cases of the myocarditis as part of the Maverick paper that we published in Circulation EP. What I find very interesting is the early stages of myocarditis are oftentimes very difficult to be picked up by cardiac MRIs. Obviously, I mean, even T1 imaging sometimes is not as good as the FDG PET scan. So, Dr. Ajit Kumar, do you have any comments on when you're dealing with evaluation of early forms of myocarditis, and do you recommend using both an FDG PET as well as an MRI together with T1 T2 weighted imaging? Or do you think it's actually waste of resources to really do an MRI in somebody where you suspect an acute or subacute myocarditis, where your yield is much better with an FDG PET scan? Any comments on that or insights?
Yes, if it is quite early in the myocarditis phase, we can use a T2 weighted imaging and see if there is any evidence for it. But if you have crossed that period of about a month, and if you're in the subacute or later phase, then it becomes difficult. And if it is difficult, then you got to rely on LG enhancement and T1 imaging. But I think if you have a strong suspicion of any of the etiological causes of myocarditis, then an FDG PET would certainly help, especially any of the other forms of myocarditis, like if you suspect sarcoid and other varieties. And that is the point at which we would do, because an FDG PET would certainly combine with a CT PET would involve cost. But I think for the diagnostic purpose and the therapeutic role that it has, I think it certainly should be done.
Very good. And I have another comment on atrial fibrosis. Years ago, we did a small project understanding the concept of atriomyopathy in non-rheumatic heart disease patients. And what we found was very interesting. These are the patients that actually have very severe sinus node dysfunction with extensive scarring. I mean, even in the order of 70–80% of the atrium being completely scarred, with really no significant LV enhancement, with well-preserved left ventricular ejection fraction. And these are the ones that you look around and see that the ones that have significant restrictive patterns of filling and all of that. So what are your thoughts on these specific groups of populations where, in the absence of an obvious inciting factor like rheumatic heart disease, and you see this mostly in the Western populations where these are typically women that are in their early 70s, end up with a rapid progression of atrial fibrillation from paroxysmal to a more persistent form of arrhythmia, sinus node dysfunction, and you thought that these are classic paroxysmal atrial fibrillation cases and you took them for ablation, and you end up realizing that their atrial substrate is so extremely scarred out. So these are specific lone atriomyopathy type of situations. From a pathophysiologic aspects, what do you think is happening in some of these cases?
So I have a feeling that some of these elderlies who have developed paroxysmal AF, they are likely to have some amount of diastolic dysfunction and raised BNP, and which will give you a clue to do an MRI. It is quite likely that atrial fibrosis is a component in these patients, which I think we have not been addressing these issues very specifically. Whether you would put them into an atrial cardiomyopathy or early phase of atrial compliance failures, that is different. But as far as the cause, the atrial fibrosis actually is a cause, gets into a driver mode for AF. It is not purely a pulmonary vein-related issues or which can be taken care of by pulmonary vein isolation. And I think there are likely to be atrial fibrosis and drivers of AF in them. The clue to that could be even in a simple BNP, which may be elevated for you to sort of check. So whether it's related to a heart failure with preserved ejection fraction and atrial dilatation and the consequence of that.
If I may add, in this kind of, to add Dr. Lakhireddy's question, there have been some patients who have not AF, but atrial tachycardia, who have no reason to develop a scar, no myocardial infarction, no LV dysfunction, no rheumatic heart disease, yet been found to have extensive scars in this, not only RA, not only LA, but also extensive RA. I'm not sure what is the pathophysiology of it, but these were found on 3D mapping and later on confirmed on MRI. Did you see any such cases, Dr. Lakhireddy?
So we tried to utilize the cardiac MRI program again, like any place else. When you have a good MR cardiologist, the quality of the images that you get is very good, but oftentimes that is the biggest rate limiting step here, right? So the technician goes away, and then things that you deal with are different. So overall, we have not been very happy with the quality of the MR imaging at our institution in the last 2 to 3 years, and so I kind of moved away from doing some of these things just for that reason. Now we got a new guy that joined our practice that is actually MR trained, so we will sort of reintroduce him. So that's kind of where we are. There was a question for Dr. Ajit Kumar, specifically about risk stratification post-myomectomy or post-alcohol ablation. How do you really use MR imaging in risk stratification when somebody undergoes myomectomy or alcohol septal ablation? Do you still?
Yeah. I have some information on patients who have had alcohol ablations. A few of the patients, so you find a lot of extensive scars in them, and my feeling is that cannot be used to quantify the LG, which as an indication for primary prophylaxis. Myomectomy, I'm not sure actually what it is, but I would like to bring about a point here. See, there is a concept in a lot of people that as the radiologist reports, LG is seen and present in hypertrophic cardiomyopathy, there is a tendency to go for a primary prophylaxis with an ICD. I think that is wrong. Almost 50% of your patients will have LG if you do an MR for hypertrophic cardiomyopathy. It is not the presence of LG, but the quantum of LG which is significant. So about more than 15%, only it becomes significant when you're considering for primary prophylaxis. Otherwise, 50% of your entire hypertrophic cardiomyopathy population is going to get an ICD. So you need to be careful at that. Read that MRI carefully.
Great. I think this was a fantastic discussion. And any other questions from the audience? Haigrave, you want to wrap it up with your comments?
Yeah, there was some of this, Lucky, there's some of the questions, still there's some questions we have time. Could you finish off the questions, Lucky, please?
Yeah, sure. Let's see. There was a question about scar heterogeneity versus LG scar burden versus ejection fraction for prediction of sudden cardiac death and ventricular arrhythmia. So in that order, Dr. Kumar, what's your take on, if you have to really match them up, do you rely more on EF or LG scar burden or on scar heterogeneity in predicting ventricular arrhythmias as sudden cardiac death in an ascending or descending order?
Yeah, I think the ejection fraction and LG burden needs to go together. So in patients with less than 35%, you need to look at the LG also. That's one. Now the scar heterogeneity, if you are really critically looking at it, it is actually more useful in ischemic cardiomyopathy. It is not as much useful in the non-ischemic cardiomyopathy patients. So I would put, you need to look at EF and LG together. Scar heterogeneity, probably not proven as far as the need for an ICD is concerned, but it certainly gives a clue to the presence of arrhythmias. And if you are somebody who's keen on or who's going to take on VT ablation, then I think we need to be have a little more software and interest on that scar heterogeneity assessment. And ultimately, I think in a couple of years, the software will be there where you can integrate the MR maps onto the EA maps. Are you people doing it at your center?
So PRJ's group actually has this small company called the InHeart mapping system, where they actually integrate the either MRI with delayed hyper enhancement or high intensity CT scan imagery that you can actually integrate into the 3D mapping. So we don't use it at this point in time, but we're in the process of evaluating that particular software to be able to do that. So a few centers in the US, like the Hub guys and I think Rottung in University of Chicago, have access to this software, and they've been using it for a while. And I think it makes a tremendous difference in the quality of the work that you could do. And it also significantly minimizes your procedural time as it makes these channels like very, very much obvious. So on that note, I think appreciating the scar heterogeneity and being able to identify the channels during the ablation, I mean, this is a concept that we have kind of introduced back in 2011 when we first started the substrate approach rather than the induction and mapping approach, where almost scar homogenization really become standard of care in many centers at this point in time. I think the utilization of pre-procedural MRI integration into the 3D electron-atomic mapping with scar homogenization, I think will be a paradigm shifter in many ways, as it has been for us in a lot of places. So we very much like that. So anything else? I think that it was actually a fantastic session. Thank you very much for a very educational event. And Vanita, again, I say kudos to you. This has been the most successful educational program compared to many other places around the world. So I say the Indian Heart Rhythm Society has really stepped up the game. And I actually speak about this all the time to the HRS folks. The consistency and the scientific rigor of the program is amazing. So congratulations to you all. Thank you very much for a very useful session. Thank you, Dr. Ajit Kumar, and Haigrave, thank you very much.
Thank you so much, DJ, for the kind words. Thank you, Dr. Ajit Kumar. It was really, really, really so nice. And thank you for taking out time for this. And Haigrave and Dr. DJ, hats off to you. I think we can sign off.
All right.
Thank you. Thank you very much.